So our next speaker, I hope you already know him. He will talk about crossing the mesh.
Yeah, it's quite far away from the inclisiran, but it's also important sometimes to how to cross the mesh. I would like to ask Professor Gelev to join us in the panel, because it's a session for tips and tricks, and you are part of the panel. Thank you. Thank you, Valerie, for coming. Welcome. Welcome. Nothing special to disclose about this, this presentation. You probably know, or probably not, multi-layer flow modulator with a big hope for treating patients with aortic aneurysms, and lately patients with aortic dissection. This is a three-dimensional, self-expanding, tubular uncovered stent with interconnecting layers, 3 to 5 layers, of braided cobalt alloy wires, and with mesh porosity of 60 to 70%. This is crucial. The idea of this porosity is to allow side branches perfusion. And in addition to the sealing treatment, like in this case shown in the graphic, by endografts on the level of the aorta in case of aneurysm, the idea of multi-layer flow modulation is to centralize the flow. So to laminate the flow inside the stent, but very interestingly also to laminate the flow through the mesh. So the idea is to avoid turbulence, to decrease mismatch of the radial force, and to, in fact, to centralize the flow into the true lumen for the aortic dissection in case of dissection. And in fact, many trials have shown good results in the early period, and excellent results regarding preserving the flow into the side branches. We implanted and published one of the first in the history of the medicine, multi-layer flow modulation for aortic dissection type A in a young patient in a critical condition, in which in a bailout situation, he was dying. In a bailout situation, we implanted a multi-layer flow modulation from the ascending aorta across all the brachiocephalic vessels, all the way down to stents to the renal arteries. And he survived, and he's still living 7 years after the procedure and 5 years after the publication of this case. And in fact, the bench tests were showing that the side branches stay open for all the cases in which there is no additional disease. So in case the patient stays without additional atherosclerotic disease, the branches, they don't suffer anything reduction of the flow. But what if there is a atherosclerotic disease? And this is the problem, that this more than 95% patency, it's really true. But in fact, there are between 5 and 6% of patients that they have atherosclerotic advanced disease, and in this situation, it will be a challenge. Is it possible? The big question is, do you think it's possible to cross the dense mesh? It's a really very dense mesh, and it's I can admit that it's not easy. So the osteo-engagement of the catheter is not possible because the strut size is so small. It's probably 1 to 2 millimeters is the strut size. There are multiple, but the pores are very small. And because of that, in the majority of the cases, we have to, let's say, to treat the side branch pathology from a distance, because it's very difficult to engage the catheter unless you do several tips and tricks. One of the tricks is to engage a balloon inside the mesh and to use the balloon as an anchor in order to introduce the catheter inside the mesh, in order to have the possibility, for example, in this critical osteostenosis of the superior mesenteric artery, the game is even more difficult because there is not only critical osteostenosis, but there is a mesh before the stenosis. So we have to cross the mesh, and this is one of the patients treated for AAA with a bifurcated version of the MFM. And you see what we are doing. We are crossing with a coronary wire. We are crossing with a coronary balloon with incremental size, starting with 1.5, 2, 3, 4, 5 millimeters, and finally crossing with the guiding catheter in order to have the possibility to implant a stent. So in this is our experience. I have to admit that our experience is much better in dissection, not in aneurysm. It resulted during the years that for big aneurysms, especially in aneurysm bigger than 6 centimeters, the MFM doesn't work because there is not more the possibility for shrinkage of the aneurysm, and in most of the cases this non-sealing strategy doesn't work. But in this situation, we have calculated that 94.8% of the branches that our experience we covered stayed open, and we had several patients, in fact in 4 patients 5 lesions that are de novo lesions that appeared after the implantation of the stent. And I will 3 of the cases that we have performed in this cohort of patients. This is a 62-year-old male with osteostenosis of the superior mesenteric after 4 years after the MFM implantation, with abdominal angina, with not very good communication in the rheolan anastomosis between the trunk and the mesenteric. And as I already described, this was the step-by-step anchoring of the catheter before implanting the stent. You see, this is in fact the stent positioned and opened after crossing the mesh with the catheter, and this is the final result. You see full restoration of the flow and full elimination of the osteostenosis. This is another case with a bifurcational treatment. You see, with 84 years, quite elderly guy, with de novo subtotal occlusion of the celiac trunk. And in this situation, you see that it's not strictly osteal, but it's almost osteostenosis of the celiac trunk, and even more dramatic with total occlusion, chronic occlusion of the inferior. In this picture, you can observe very well both the celiac trunk and the superior mesenteric stenosis. We succeeded to open both of them, and utilizing the same strategy with incremental. This is, you see how good is the result for after the implantation into the osteal part of the mesenteric, and after that the osteal part of the celiac trunk. In some of the cases, in fact, it was not possible to cross with a peripheral stent, and we had to implant coronary stents with quite good results. You can observe this is the result after the implantation into the celiac trunk, the coronary stent off-label, of course. The third case is a 62-year-old male with stenosis of the left renal artery. And again, by the upper approach, we succeeded to go to the renal artery and to implant again a coronary, formerly coronary onyx stent in this renal artery. Fortunately, the renal arteries are they are accepting and they stay with good results because most of the renal arteries are between 5 and 6. So with some overexpansion of coronary stent, it's possible reasonably renal artery to be treated. As a take-home message, I would say that reintervention after multi-layer flow modulation stent implantation of side side branch is rare, but not unusual procedure. It's challenging because of the stent nature, mesh density, and the operator must cross triple layer. Using several endovascular tips and tricks, the procedure can be performed successfully and safe in most of the cases without the need for open surgery. And thank you very much for your attention.
Thank you very much for showing us these very impressive cases. And that is always a problem, that when we, also you know there are different techniques also in the aortic implantation of endografts. Yes. So sometimes we place them parallel, a stent first in the renal and then cover it and so on. Also that is sometimes,
Absolutely.
but that is very, I never had any doubt that you can cross these multi-layer mesh stents. Are there any comments or questions? Yes, please.
Slovo.
Do you have experience with covered stents inside branches as papers?
We can join data. We have, in fact, head-to-toe interventions with papyrus for different kinds of pathology. AV, fistulas, aneurysms, of course, in visceral, splenic artery. In many cases, the splenic artery is very tortuous. With a peripheral stent graft, it's almost impossible to go there. So having in the armamentarium our cardiology, catheters and wires, they are extremely flexible. And the papyrus stent is 5 French compatible. It's the unique one. There is no other. So the papyrus, I remember one dramatic case, and we publish it. A guy that after a car accident, he had a huge communication between the carotid and the sinus. And the venous sinus, the cerebral venous sinus, and it was not in fact a fistula, it was a window. It was huge. And we implanted two, with telescope, two, one after the other, overlapping stents, and we post-dilated with a 5mm balloon. It's after the siphon part of the carotid artery, and because it's extremely flexible, it didn't happen anything, no dissection, not traumatic injury of the intima of the carotid, and the fistula closed. And the patient survived. He was in coma. He was in coma. His exophthalm on the right eye was 2 centimeters. So the eye was outside the orbita because of the huge hematoma that was behind, and with the papyrus we succeeded to save his life, in fact. And but I'm not joking. We have to join the data and to publish, because it's probably a crazy idea, but it works fantastically well.
About the cardiac stent, because probably I'm the only one, except you in Bulgaria, who had to cross the cardiatis because you implanted this. And before you remember this case. Yes, that was the patient who thrombosed because the colleagues stopped antiplatelet therapy, and I had to open the thrombosis of the cardiatis stent. Actually, that was a thrombosis of the aorta. Mm-hmm. And then I remember how difficult it is to cross the cardiatis with any, I mean, you will cross it with the wire, and then it starts very interesting part that practically you can inflate the balloons, but when you deflate the balloon, the stent returns.
There is a recoil, yeah.
Absolutely,
there is a huge recoil.
And this is why I'm just wondering how you implant stents across the cardiatis, or this is at very ostium of the side branch placement of the the vessel.
No, in fact, always we are trying to make the stent crossing and protruding slightly into the lumen of the cardiatis itself. So we are crossing first with the catheter with this anchoring technique, and after the intubation with the catheter, we are going under the protection of the catheter. We are going with the stent to cross the mesh. And after, during the retraction of the catheter, we are protruding slightly with the proximal part of the stent inside the MFM itself. So it's in order to engage the stent inside the ostium.
Okay.
Yeah.